Hello, everyone, and thank you very much for coming to today's session. It's my pleasure to welcome you to the first of two webinars this month on the topic of the NHS and your care, part of our Living Well with Prostate Cancer webinar series. For those of you who haven't met me before, my name is David James, and I'm the Head of Patient Projects at Prostate Cancer Research. So Prostate Cancer Research, we are a medical research charity that's focused on the prevention, diagnosis, and treatment of advanced prostate cancer and delivering better quality of life outcomes for patients. We're proud to fund 15 high-quality, innovative projects right across the UK with a shared aim of developing breakthrough treatments so that we can one day live in a world where people are free from the impact of prostate cancer. So scientifically speaking, cancer, it's a very complicated disease. It can behave very differently from one person to the next. And so for that reason, we will probably always need a whole menu of different treatments for it. So we make sure that our researchers are all taking very different approaches. And that gives us a number of different lines of attack. And the hope is that eventually everyone, no matter how their prostate cancer behaves, will be able to pick that perfect treatment off the menu. And then if their cancer changes, then they'll simply be able to pick another treatment off the menu to switch on to. So I'm not going to obviously talk through all of our research projects today. I know that's not why you're here, but I just wanted to introduce you to a few of our scientists who actually make this work possible. So the lady on the top left here, she's Dr. Christine Perlustian in London, and her team are trying to use our natural immune systems to destroy prostate cancer. On the middle row, second from the right, is Dr. Jorge de la Rosa in Cambridge. So what his team are doing through your and many others' generous support is really delving into a protein which should stop cancer from growing. And so he's asking why it stops working in about half of prostates, and then if we can use that knowledge to essentially find a new off switch for cancer. Then on the middle, at the far left, is Professor Dan Brewer in Norwich. So he and his collaborators are really using IT and machine learning to see if we can divide and conquer prostate cancer. So if we can actually, by looking at an enormous amount of data, work out which cancer needs to be treated, which can be safely ignored, and then which treatments should be used for each individual person. And actually, Dr. Brewer and his team are actually going to be giving one of the webinars next month, towards the end of next month, on the future of treatment and really talking about AI and machine learning. So, obviously I'll be sending around more details about that later on. So these are just some of the examples of some of the newer approaches some of our scientists are taking. But we also researched many of the main treatments currently being used at the minute to see if we can make them better. So we have two projects currently working on hormone therapy. So this includes the gentleman on the top row, and the second from the right up here is Professor Ian McEwen from Aberdeen. So he and his team are working on, are trying to make hormone therapy work for longer. And then the gentleman on the top row, far right up here, next to Professor McEwen, he's Dr. Luke Gaugan from Newcastle, and he and his team are investigating how prostate cancers become resistant to hormone therapy, and then how we can actually stop this resistance from occurring. So if you'd like to actually have the opportunity to meet some of our scientists directly and hear from them about the projects that we're funding, we're actually going to be hosting a Meet the Scientists event in early March 2022, and that'll be taking place in Manchester. So I'll share more details closer to the time. But hopefully, if that's something you're interested in, one for the calendars. So obviously, beyond our research, we're also dedicated to educating, empowering, and supporting our patient, partner, family, and carer communities. And that's why we launched this webinar series, Living Well with Prostate Cancer, in collaboration with our good friends Tackle Prostate Cancer, who are the UK's National Federation of Prostate Cancer Patient Support Groups. So for those of you who are new today, just a few housekeeping points before we begin. This is a Zoom webinar rather than a Zoom meeting that many of us are familiar with. So that means everyone who's attending, their videos and microphones are muted. And this is so we can actually record this session and then share it around with anyone who wasn't able to attend, and also share it around with you afterwards, and if you'd like to watch it afterwards. So we have two wonderful speakers with us today. We have Chris Lomas, who is the Living With and Beyond Cancer Program Manager at NHS England and Improvement, and Debbie Victor, who is a Uro-Oncology Clinical Nurse Specialist at the Royal Cornwall Hospital. So after their presentations are complete, we'll open up to questions. So Again, there's for those of you who've been here before, you'll know there's no chat function, but there is a Q&A option. So if you have any questions at any point during the session for the speakers, feel free to just pop them down when they come into your mind, and then we will address them at the end when we open up to questions. So without further ado, let me please hand over to the first of our speakers today, and I'd like to hand over to Chris Lomas. Chris, over to you.
Thank you, David. Can you see and hear me?
Yes, indeed we can.
Okay, excellent. Well, thank you very much. And that was very interesting, hearing about the research that's going on. That's fantastic. Hello, everybody. Good afternoon. My name is Chris Lomas, and I'm the Living With and Beyond Cancer Programme Manager in the Living With and Beyond Cancer team, which is part of the National Cancer Programme within NHS England. So I'm here today to talk to you about the work of our team. So if I could have the next slide, please, David. So how did Living With and Beyond Cancer come to be? So just to give a bit of background to the terminology and to our work, it really came out of the survivorship movement, which you may have heard of, that really gained momentum around 2008, very much championed by Macmillan and other cancer charities. And the aim was really to set about improving support and outcomes for people affected by cancer. And this initiative was adopted by the 2015 National Strategy for Cancer in their strategy paper, Achieving World-Class Cancer Outcomes. And within that paper, recommendations were made, and then these have been incorporated into the NHS long-term plan. And this is really the sort of policy document that we're working to within the NHS to deliver changes and transformation across the service. So specifically within the long-term plan, there's a section on cancer, and there's reference to what we need to deliver within the Living With and Beyond Cancer team. So if I could have the next slide, please. So these are the Living With and Beyond Cancer commitments that we are delivering from the NHS long-term plan. So this is really around acceleration of the commissioning and provision of services to support people affected by cancer to live as healthy and as happy lives as possible. There's 4 elements. There's personalised stratified follow-up, which is a slight change to the follow-up pathway that is applicable in certain cancer groups for certain patients after they've finished treatment. There's the personalised care interventions, which are personalised care and support planning, holistic needs assessment, end of treatment summaries, and cancer care reviews, which you may have heard of, which I'll talk about a bit further along. And there's the managing the impact of cancer. So we're looking at what else we can do to support people. So we've moved from just surviving cancer. We want people to live well. It's the quality of survival which is important, because so many more people are living so much longer with cancer, which is brilliant. And there's a quality of life survey, which some of you may be aware of, that we've been sending out to patients. And for the first time, we're getting data on what impact cancer and its treatment has on people's lives. And what we're going to do is use that information to inform us how we can progress our work to support people to manage the impact of cancer and its treatment moving forward. Can I have the next slide, please? Okay, so this is an illustration of our personalised stratified follow-up pathway. So if you look at the person at the top, that's the cancer journey. So right at the beginning, from prevention diagnosis, through to treatment, and then further along their journey. And underneath, you can see the personalised care interventions. So personalised care and support planning based on a holistic needs assessment, which is really a conversation with the individual about what matters to them. This can happen at any point along that journey, as can access to health and wellbeing information and support. So this should be easily accessible to everybody at any point in the journey. And then further along the journey, end of treatment summaries. These should be offered when treatment is finished and should be shared with you, the individual, and also your GP. So both of you are fully informed about the treatment that you've had and the consequences of that treatment, and information around worrying symptoms or recurrence, and also possible longer term late effects of treatment. And then the one at the bottom is the cancer care reviews. These are undertaken within primary care. So this could be with your GP or with a practice nurse. This should happen around 12 months after diagnosis. Okay, next slide, please. So again, this is showing the personalised stratified follow-up pathway. So at the top of the personalised care interventions that I've just mentioned that can happen at any point in the journey. And the boxes in the middle show that from diagnosis and treatment, we would then expect you to have a holistic needs assessment, personalised care and support planning, and then a shared decision about what sort of follow-up is most appropriate for you. So there are two choices of follow-up. So there's the more traditional follow-up where you will have a scheduled appointment with your consultant face-to-face or by phone. But for many people now, they're moving into supported self-management follow-up with remote monitoring. And this is where you will still have your surveillance scans and your monitoring. All of these will be scheduled as usual, but these will be done in the community, and you will only be called back to hospital if you need to be. And underpinning this pathway in the box below, these are the core personalised care components that need to be in place to support you in this pathway. So again, it's the care planning, it's information on signs, symptoms and recurrence, health and wellbeing information and support, surveillance scans and tests still, and rapid access back to clinic should people need it. And people should also know who they can ring for support. Okay, next slide, please. So, the benefits of living with and beyond cancer interventions. So we're aiming to improve physical and psychological recovery from the effects of cancer and its treatment, and improve confidence in the future, and improve people's ability to self-manage and take control going forward. So we're really aiming for a better quality of life for people and a better patient experience. Next slide, please. And also, in doing this, we will make more efficient use of NHS resources and reduce demand on some of those resources. And also, if people are better supported, then it will improve economic activity if people feel able to return to work or education, and possibly reduce the need for benefits. So it should be a better use of taxpayers' money. Next slide, please. So we've talked about the personalised care interventions. So what is personalisation at its heart? So personalisation means that services and support should be tailored to the needs of every individual rather than being delivered in a one-size-fits-all fashion. So at the heart of personalisation and in terms of tailoring support to the needs of the individual. We're really talking about a shift in relationship between public services, such as what's happening in social services and social care, and the NHS and the people that they serve. So next slide, please. So this shift in relationship changes the way that things are done. So the shift in relationship is really at the heart of personalised care, and it has these aspects. So patients shift from being a passive recipient to an active participant. So we're aiming to move, instead of being told what to do and prescribed what others think is best, for people to actively take part in having their views valued. And a shift from being ill-informed to being well-informed through the support of health and wellbeing information and support with self-management education. And a shift from being given isolated boxes of treatment to having support integrated in the round, around the person. Next slide, please. Oh, so we've got a short video, which hopefully we can play, which might explain the drive within the NHS to implement personalised care.
Since it was founded 70 years ago, the NHS has been there for us all. Yet today, our health and social care system is facing more pressure than ever, with increasing financial, operational and demographic challenges, and 70% of the budget now being spent on supporting people with long-term conditions. The system can also sometimes fail to deliver on the things that people really value, such as being listened to, having a say in what happens to them, experiencing a joined-up service, and being treated with dignity and compassion. Therefore, the need for the system to move towards a personalised care approach is now more urgent than ever. So what is personalised care? Personalised care is where people have more choice and control over how their health and care needs are met. It recognises that people themselves can sometimes be the best integrators of health and care, and supports them to live as independently as they wish. With personalised care, people are more involved in the decision-making process and should be supported to talk about the outcomes that matter most to them and what is the best course of action to achieve these outcomes. The result is better health and well-being outcomes for them, plus more effective and joined-up services. People aren't left on their own, but are supported to develop their knowledge, skills and confidence, and can take on as much responsibility as they want to manage their health and well-being. The NHS will, however, always be there to support people, as it always has done. As we move towards offering a more personalised system, it's important to have a clear approach, and that's why we've established our comprehensive personalised care model. This is an all-age, whole population approach to personalised care. It focuses on helping people to achieve better health and well-being outcomes by accessing specific personalised care interventions. To start, the whole population can be supported to stay as well as possible through community resilience and enabling people to make informed choices when their health changes. There are a number of universal interventions which help to achieve this, including shared decision-making and patient choice, which means treating people as equal partners in decisions about their care and treatment, and social prescribing and community capacity building, which means building relationships with voluntary organisations and referring people to non-clinical local support services where appropriate. The next group are people with long-term physical and mental health conditions, who make up around 30% of the population. A personalised care approach supports these people to build knowledge, skills and confidence to better manage their health and well-being through a series of targeted interventions, in addition to the universal interventions. These include personalised care and support planning, which is a proactive process bringing together people's physical, mental health and well-being needs into a single process and joined up plan, which is focused on what matters to them. Support to self-manage. The patient activation measure can be used to target these interventions, including health coaching, self-management education, and access to peer support. The third group are people with complex needs, who typically have multiple long-term conditions and a functional impairment, and who make up around 5% of the population. A personalised care approach provides intensive specialist interventions to empower these people and integrate their care and support so as to reduce unplanned service use. These interventions include the targeted and universal interventions, as well as personal health budgets, integrated personal budgets, and integrated personal commissioning, which enables people to take direct control of the resources available for their health and care. Finally, the model recognises that the system needs to be flexible and adapt to the fact that individuals often have changing health and care needs. Involving people in their own health and care not only adds value to people's lives and experiences, it creates value for the taxpayer and better integrates the system around the person. The comprehensive personalised care model demonstrates how this more personalised approach can become a reality. To find out more, visit england.nhs.uk.
Okay, thank you. So next slide, please. So that was just, I think, quite a good illustration of the work that the personalised care group are doing within NHS England in terms of their ambition around delivering the comprehensive model of personalised care. And from our point of view within the Living With and Beyond Cancer team, we do work very closely with them to ensure that we can support the delivery of those personalised care interventions that are appropriate to support people affected by cancer. So just to follow on from the video, really, in terms of personalised care, these are just a few drawings which I think illustrate the value base behind personalised care. So it's really about a shift in the relationship between the health and care professional and people. So instead of being told what's wrong with you and how your health needs will be met, it's a shift to being valued as an active partner in conversations and decisions about your health and well-being. So although we recognise that the clinician is the expert in that condition, you are actually the expert of yourself. So you know yourself best and what matters to you, how you respond to things, what you like. So it's about recognising the partnership that you and the clinician need to develop to ensure that your needs are appropriately met. Next slide, please. And again, this is the shift in that relationship. So we, instead of being asked what's the matter with you, we now expect that people will be asked what matters to you in their conversations with healthcare professionals. And the next slide, please. And again, as I said, it's a shift in that balance of power. So rather than feeling powerless in a complex health and care system, we want people to feel empowered, and that they're working in partnership with their health and care professional in terms of working towards outcomes that matter most to that individual. And then the next slide, please. And it's a real shift in the relationship between a one-size-fits-all approach, which we know doesn't meet everybody's needs and outcomes, to supporting people to have more choice and control over how their health and well-being needs are met. Next slide, please. And again, moving from being seen as a patient with symptoms to a shift to being seen as a whole person with skills and strengths and attributes, as well as needs to be met. And then the next slide, which might be my last slide. So this shows the components of the comprehensive model of personalised care. So it talks about shared decision making, enabling choice, social prescribing, health coaching and supported self-management, personalised care and support planning, and personal health budgets. And if you just click again, please, David. This shows the personalised care interventions that we're working to deliver for people affected by cancer. So we've got the personalised care and support planning based on the holistic needs assessment, which will be a meaningful conversation that you'll have with your healthcare professional to support you to develop their care plan to achieve the outcomes that matter most to you. The end of treatment summary and access to timely and appropriate health and wellbeing information and support. This will support in building your confidence and knowledge and skills around your condition and how best you can help yourself to manage it. And then the cancer care review in primary care. So again, this will be with your GP or practice nurse, and it may be that they help connect you to services and support that can really help you in the community. And I think that's everything from me. I will be staying around for questions and answers later.
And over to you, Debbie.
Thank you very much, David, and thank you, Chris, for your introduction to what today's webinar is essentially all about. So whereas Chris gave a very succinct overview of the whole package of personalised stratified follow-up, I'm going to pick on one specific thing, which is which is supported self-management. So I'm Debbie Victor and I work in Cornwall. It's not sunny here today, it's absolutely tipping it down. Next slide, please. So I have been a Uro-Oncology Clinical Nurse Specialist since 2004. Quite a lot has changed in that time. We're seeing men with prostate cancer having earlier diagnosis, longer follow-up times, and lots more treatment options, and even men with metastatic disease are living a lot longer. I think I was reading something the other day on the Cancer Research UK statistics, 84% of men making it to 10 years with prostate cancer, so that's pretty good. Initially, when I first started as a CNS, I took on a nurse-led telephone follow-up in 2005, but when the numbers were increasing every month and we were up to about 200 patients a month, it became almost unmanageable. So we were approached to be part of a pilot study for the remote supported self-management, which was funded by November Foundation and facilitated by Prostate Cancer UK in this country. So, and we were very lucky to be a part of that in 2015, and we haven't looked back. We've now got about 2,000 men on this pathway and all quite enjoying it. So before I carry on, You'll have to excuse my perm in this photo. It seemed like a good idea at the time in this video, but I'm just going to ask David if he could please play the video.
If I said to you, you've got cancer, you now have to dance to my tune essentially. You have to be here at this time, you have 20 sessions of radiotherapy at this time, you have to change your life upside down based on what I'm telling you. You lose one of the things that I think makes us human, and that is control over your day-to-day life. Well, when you think about how empowering a project like this is, it's saying to a patient, you can have control over how your life continues after your prostate cancer treatment. We will support you through that. I think that's very powerful.
From a healthcare professional's point of view, numbers of prostate cancer sufferers are growing and growing and growing every year. And we're catching it at an early stage, so there's more and more men that have got it, but we're not doing anything. You've got a long surveillance period after. We're going to drown if we have to keep all of those men coming to clinic. Supported self-management is helping people get out there and be the person that they were before. Hi, how are you?
Nice to see you.
Free of having to come to certain appointments, and it allows well people to be well at home.
First of all, they come to a workshop. Quite often it's the first time that those chaps have sat with another person that's had prostate cancer treatment.
I went to the doctors 7 years ago, having trouble with a few things, and he said, oh, it sounds like prostate. He said, can I have a look at it? And I said, yes, and up my mouth, and I mean, I didn't even know what my prostate was.
We talk about healthy lifestyles, side effect management, setting goals, getting back to the person that they were before cancer entered their lives. And then we give them the tools and we take a step back.
It's been fantastic. It's helped me stay in work, not spend time sitting in the hospital for hours on end waiting for results. Had my bloods done, had my scans done, had my x-rays done. It was absolutely brilliant, just being able to do it online or at the end of the phone. It was fantastic.
But if there's something there that you think, well, that's not quite right, then we can either contact them by email or by phone, and they don't have to start afresh. They're not going and seeing a new person. It's very much about lifestyle. Whilst we hope they don't need us, we're there if they do.
It shows that this myth that older men and prostate cancer patients and men in general won't want to engage with their health or technology is just that. It is a myth. Prostate cancer patients do care about their health and they will engage with a project if you give it to them.
There's a personal element here. You're actually communicating with people that you know that looked after your healthcare in the very first place, can make decisions for you, despite the fact that this is all happening remotely on the internet through a screen.
I just thought, I wonder what my PSA level is. So I looked online and there it was.
I didn't have to check with anyone. I didn't have to ring the doctor. I didn't have to ring you. It was all there.
You know, those guys are keeping an eye on you. I find that very reassuring.
That can only occur with a system such as this. A quality of life it's the most important thing of all. 66 years old, I'm still working as a trekking guide. There's no reason not to carry on.
The Movember Foundation being able to fund something like this is great. Still at work, still enjoying my life, meeting friends in the pub, have a pint, walk with my wife, have a nice meal, go out on my motorbike for a ride with friends. I want to carry on with life as I was doing before I got told that I had it. And that's what I've done.
Movember, just because it's fun doesn't mean it's not putting out a very powerful message and delivering huge help to us as clinicians and patients as prostate cancer patients. And all of these things play a vital role in moving not just the treatment of prostate cancer forward, but patients' experience of that treatment and how they manage the rest of their life thereafter. I see this as our standard. And I could not go back, and I would not go back to an old-fashioned clinic-based follow-up for well people.
So hopefully that video was able to give you a bit of an insight into what remote supported self-management is. We were one of 5 pilot sites. All sites have embraced it. It's now moving out, and there's different formats of this, but I will talk predominantly about the one that we use here in Cornwall and the one that we were piloting. So the patient is selected from the a clinic as being suitable to move on to this programme. I'll come on to that in a short while, but when they are registered on the system, they have a screen that they can log into. It's a bit like internet banking in that you have a link and you have to log in using your own login details and password. And if you were to be sent a result, then you get a link to, you get a reminder into your email box to log in and have a look. Not that many men need reminding to have a look at their PSA. But the beauty of this system is that it links to the hospital laboratories. So as soon as it rolls off the laboratory, it's there available online to see, whether it's Sunday or Friday night after you've watched a football match or whatever, it's there. So the landing screen, it has PSA that comes up as a flow chart, but there's also, it comes up as a column of numbers, but also there's a graph at the bottom of that. There is also the facility to contact the clinician. That's like an email service, and the message goes to a monitored email box Monday to Friday. And there's also a 10-year schedule of when your next PSA is due based on what your disease is and what treatment you've had. There's also a thing on there called a health MOT, and I think I've got a picture of that later. So next slide, please. So this is a picture of the PSA. So it shows, like I said, in column form, what the results are. It's only populated from when you're registered on the system, so it wouldn't have every single PSA you ever had done, although we do try to make sure that there's at least sort of 3 or 4 on there when you log in. And it is stratified to each person. Next slide, please. So why is this necessary? And I think Chris mentioned this, but also it was mentioned in the video there. Keep well patients out of clinics. 1 in 2 people in their lifetime will develop cancer. And the lovely researchers are getting better at treating cancer, even when it's spread elsewhere. So people are living longer. And what we don't want is to impact on you getting out there and living your lives at the expense perhaps of people that have got problems that do need that support. And as demonstrated in the video, where sometimes you can move into and out of your level of need, this programme is purely to try and give you back control, but to make sure that you know what to do if things aren't going quite right. Next slide, please. So who is suitable for supported self-management? Anyone who is stable. And like I said earlier, you have to have a tumour that expresses PSA, because unfortunately some prostate cancers haven't read the book about PSA and don't realise that that's what they're supposed to do. So each team, hospital team, whether it's a network or the individual hospital, will set a protocol for who is suitable, what level they should be at post-treatment, and what their recall level should be. So it is personalised in a way, but it tends to be your urology consultants and the oncology consultants and the nurse specialists will get together, come up with a protocol, but sometimes it will be tailored specifically in a way to the individual. And when you're registered on the system, it's definitely tailored to you. So post-surgery, if you've not got any ongoing problems, post-radiotherapy, again, if you've got no ongoing problems, people on active surveillance, once you've had your first 12 months and your repeat MRI or biopsy can move on to this programme with strict recall criteria written by the consultant. Men on hormone manipulation, and sometimes some hospitals do intermittent hormone manipulation, and those people are also suitable to go on to this, and also men on watchful waiting. So pretty much basically anyone with stable prostate cancer. Next slide, please. So this is an example of what we use here in Cornwall. And as you can see in the left-hand column, it says what treatment has been had. And then in the next column, it's at what point you should consider referring men to this programme. Sometimes for radiotherapy, for instance, consider 6 weeks post completion of radiotherapy. But if people have still got ongoing problems with bowel or bladder toxicity, then it's perfectly feasible to try and sort those out and perhaps bring them back to clinic once more after 3 months before referring them. The standardised follow-up is there going up to, I mean, we used to go up to 10 years. We're actually giving patients a bit more control and moving them out towards the GP a little bit sooner with their care plan. Oh, that's gone a bit blurry. Yes, it's my eyesight. Right, okay. David, my slide has gone a bit blurry. I don't know if there's anything that you can do. I'll go on to the next slide. Hopefully that one will be okay. Okay, so giving back, the benefits to you of this service is it gives control back. It's digital, so it allows 24-hour access. Admittedly, you won't necessarily get a response at 1 o'clock in the morning when the question has popped into your head. But if you've got a question on your mind that is stopping you from getting back to sleep, then there's no reason why you can't log into this, fire off a quick email, and then you should. The aim is emails are responded to within a 48-hour working day, and telephone calls are responded to within 24 hours. The advantage with the system that we use is you do have a direct phone number to ring the clinical team. This may not necessarily be available in all hospitals across the country. Depends on what your local team have decided to do. But there's usually some support still available, and the whole band of CNSs. The team can signpost you to help, sort of self-help. If you've not found that, they can certainly do that. We also can book you back to clinic if you've suddenly developed a problem with your continence, for example, and it's all down to your pelvic floor. We can refer you direct to physio. We can refer you if after radiotherapy you get any bleeding. We can refer you direct for a sigmoidoscopy or a cystoscopy without you needing to go through the gamut of waiting for appointments at the doctor's surgery and then coming through afresh. So we can do those sorts of things from this system. And on our system, you can see your PSA in real time, not have to wait perhaps a week or more to be able to see it. Next slide, please. So moving on to this, ideally, as Chris said, you should have a care plan or a discharge summary once you move from formal hospital follow-up. And we make a point of copying the letter to the patient so that they know exactly what's going on. I'm a great believer in a patient having a copy of their own letter, because unfortunately, if you go to your surgery 4 years down the line, that letter that we've sent about when your recall should be, if your PSA goes up, will be buried behind an awful lot of other things in your file and may not be at the forefront of the person you're seeing's mind. GPs have got thousands of patients on their books. You've only got you to be concerned or worried about. So it's in your interest really to know how often you should be having your blood test and when your PSA alert, what your PSA alert level is. No prostate should be no PSA. Your recall alert level should really be as soon as your prostate cancer starts making PSA again, or certainly at 0.2 and not more than that. And you should know who to contact if there is an issue. In some places it will be a re-referral via the GP, but in other places it won't be. But as I say, you're the person who knows you best and you know your results best. When a doctor's surgery gets all of the blood test results through for that day, quite often it's only those that are outside of normal parameters that get looked at by a doctor. And the laboratory cannot report your PSA as being outside of normal parameters because you've had prostate cancer treatment. They just have the laboratories just have a range, and it's up to the individual to interpret it. So in a doctor's surgery, a PSA of 2 is normal, but a PSA of 2 in somebody who's had surgery or radiotherapy is not normal. So you need to make sure that you know what's normal for you and when you should be seeing a doctor again in the hospital. Next slide, please. So the other things that need to be taken into consideration are possible late side effects from treatment that you've had, or possibly very rarely cancer can recur and maybe not demonstrated within the PSA. That's extremely rare. So we always make sure that the men coming to the moving on to stratified follow-up know that these are the things that they need to be aware of, and feel free to make a note of these, or I think the webinar will be available on the website, so you can have a look again if you want to, if you haven't got a pen. So bone pain lasting more than 6 weeks. Now we all know that if you do a day in the garden, you can have a bit of a backache. And I know that I got sciatica after doing a 2-day sit-down webinar thing. Too much sitting down is just not good for you. So bone pain lasting more than 6 weeks, and it's kind of quite a specific pain. I've heard people describe it as like feeling like a toothache in a bone. Blood in the poo, if you've had radiotherapy, needs to be investigated. Unfortunately, bowel cancer is also a common cancer, and it would be very remiss of us to say, oh yeah, you've got blood there because you've had radiotherapy to your prostate. It needs to be checked at least once. Blood in the wee should be checked. Unfortunately, just because you've had one type of cancer doesn't mean that you don't get another type. So any blood in the wee should also be investigated. Altered bowel habit, again, is something that needs to be reviewed. Increasing difficulty passing urine. Sometimes the treatments we give you for your prostate cancer can cause narrowing of your wee pipe, a stricture. So you might need something doing about that, or it may be a sign that there's some prostate tissue regrowth. Worsening incontinence. It's good to inform us about that, because that we may be able to do something about it that can make life easier for you. Obviously, you're a partner in this, so things like doing your pelvic floor exercises and making sure that you're drinking the right types of things is important, and they're things that you can do. And unplanned weight loss is another thing to be mindful of. Next slide, please. So on our portal, we also ask people to fill out, we call it a health MOT. We think men will be more engaged with that, but it is what Chris was alluding to, the holistic needs assessment. So pretty much the same questions, although there are some specific ones around prostate cancer. So there's the IPSS scoring system, and there's also there's an erectile dysfunction one as well on there. And as you can see from the screenshot that I very carefully took here, there's yes, no, and I would like to discuss this with someone, because you might have problems with urinating that aren't a problem and have been there for ages. So you tick yes, but you don't need to discuss it with anyone. So it's if you want to discuss something, you need to flag it. Next slide, please. So a big important part of being supported self-management is taking control, being the adult in the relationship again, rather than the doctors at the hospital telling you what you need to do. And part of being an adult is what you can do to help yourself. We can give you the treatments, we can give you the drugs, but you're a partner in this and you do need to help yourself as well. And I know that PCR have had some excellent webinars so far. So you've got your Eat Well plate, things that you should be avoiding, and things to have in a moderation, and things that will help you. And there was a webinar on nutrition and supplements. I think that was last month. So you can definitely do that to help yourself, and it's quite an easy fix. Next line, please. The benefits of physical activity, that was back in August, and I cannot tell you enough how good the exercise, both the cardiovascular, something to get your blood pumping for about 30 minutes, 5 times a week, 30 minutes a day, 5 times a week. Enough to get you slightly out of breath, but not so much that you're having to lean against a wall and can't even utter a sentence. They help with the side effect of fatigue. They help with the side effects of the hormone manipulation, if you're still on those. They help with your mental health as well, sleep, weight gain. So it's so good. And if you wanted more information, PCR have got their webinar from that back in August. That's a little bit better than my 2 little slides there. But I have also got some apps that I recommend to my patients on the next few slides. So sometimes it's like making a New Year's resolution, isn't it? We all say, right, tomorrow I'm going to give up cake. And then one of your colleagues very kindly makes a millionaire shortbread and you think, oh, actually, I'll have a bit of that and I'll have the cake the next day. Whereas if you make a pact with somebody, you're more likely to stick to it. And most of us these days have got smartphones or smartwatches or something, even a pedometer. And there are things that you can download that can be really helpful at helping you to be active. So Active 10 is an app that it tells you, the yellow on that image is telling you how when you were active during the day, but the green is when you met that Active 10, when your activity was brisk enough to count as exercise. And it's really good, and it doesn't drain the battery too much. But the important thing to note here is actually you don't need to do your 30 minutes 5 times a week all in quick succession or all together. You don't have to put your Lycra on and go down the gym if that's not your bag. You can just get out and have a walk, but make sure it's a brisk one. When I was walking my 7-year-old corgi, my walks were definitely not brisk. Next line. Thank you. So there's the MyFitnessPal. Now this one it can go, depends on your level of how much you want to be bothered by your phone beeping at you. But this, as well as going into whether or not you've been active, it also, you can scan the barcode on the side of whatever it is you're making your meal with, or you can search for your meal and it will tell you how much calories you've taken in, but also how many calories you've spent doing your exercise. So it's another quite good one. And there's a few tips and hints on there for being active. So that's quite a useful one as well. But I have to say I did delete it because I found it quite time consuming. Next slide, please. Untier. Now this one's more specific for people that have had or on cancer treatment. So your hormone manipulation. The fatigue that you can feel when you're on treatment that saps your energy isn't just normal tiredness. It's quite a strange thing that I don't think anybody that's ever not had it doesn't fully understand. And the Untier app gives you tips, tells you how to sort of refill your jug of energy. And it's quite useful, and it also helps you to give yourself permission to feel a bit tired, tips and strategies to cope with that tiredness and boost yourself. and get on with life. So that's another quite good app. So I'm not paid by the people that make these apps, by the way. It's just ones that I found and I think are really quite useful. So next slide, please. So what about emotions and fears? Again, PCR have done a fabulous webinar about this, coping with advanced disease. You don't have to have advanced disease to have emotions and fears. You can have a new diagnosis. You can be being told that we're discharging you from clinic because as far as we are concerned, you haven't got any residual disease. But having had a brush with cancer, like Dr. McGrain alluded to in that video, you know, you're dancing to our dance, and it's cancer for some reason strikes such fear in all of us. I think historically we've all lost people to it, and some of them in not quite very nice ways. So having emotions and fears is a very realistic, and even when you've been cured, you can have flashbacks and you can have concerns. A lot of my patients I know have those concerns around the time that they're having their PSA. They can pretty much put it out of their mind, and then the week before they get the blood test, and then while they're waiting for the result, those anxieties resurface. What if? So coping strategies, get out in nature. During the coronavirus pandemic, we all know how good it was to be able to get out in nature, see the trees, see a field of wheat moving, go for a walk in a park, see the colours changing in the trees. Not today because it's really raining here. Go to the sea if you can. So get out in nature, talk to someone about it. Your partner is an ideal person, but they're not always the best person. You might want to talk to somebody who doesn't have an emotional attachment to you. Acknowledge it, give yourself permission, but don't let it overwhelm you. And there's also relaxation exercises you can do. There's a wealth of relaxation apps and exercises that you can find online. There's progressive muscle relaxation. It's a quick, really easy exercise to do when you're lying in bed awake at night and your mind is going 1,000,000 to 1. Have a word with yourself, take some deep breaths, and progressively move through your body, taking tensing a muscle for the count of 10, and then relaxing it and moving on to the next bit. It's really good because I think it distracts your mind as well, because you're having to concentrate on which muscles to tense and relax. And before you know it, you've relaxed away and you're back asleep. And meditation, listening to soothing music and just imagining yourself somewhere else is also very good. So next slide, please. I'm nearly finished. You'll be glad to hear. You're probably bored of listening to my voice now. So what about sex and relationships? Because these are things that should really be dealt with before you discharge from clinic, although sometimes actually they're not something that pop into your head while you're in those immediate post-treatment phases. It might be the last thing on your mind. The first thing on your mind is, phew, that's that sorted, yay. But then as life goes back to normal, you might be thinking, hang on a minute, something's not quite returned to normal yet, and I need to do something about this. Speak to your CNS. You will still have her phone number. Speak to her. She's a good person to speak to. And if she can't deal with it, she can certainly signpost you to somebody who can, and refer you to a specialist. There is a webinar coming up, PCR again, on the ball. They've got a meeting about it in December. So that's a good place to start. Relate. I think they're not doing couples counselling as such, but they were a good place to fall back to. And it's okay not to want it. And as soon as you start talking prostate cancer, there is this thing that goes alongside, oh, we've got to talk about your erections. It's okay not to want it. You can use toys if you want to. You can just have cuddles. But don't, whatever you do, forget that actually, especially if you're a couple, that a cuddle and a pat on the arm and walking together, holding hands, goes a long, long way. Next slide, please. So sources of information, please don't just type prostate cancer into Google. You get so many things back, and anyone can write a Google page. And it's important that what you're reading and what you're trying is tried and tested. So Prostate Cancer Research have got their Treating Cancer Q&A booklet that you can order from their website. There's the Tackle website, and there's some very good leaflets that you can get from there. Prostate Cancer UK, again, they have stuff on the website you can download or you can send off for, and they also have their nurse specialists that can take calls. Then you've got Macmillan. It's not prostate cancer specific, it tends to be a bit more generic, but a good source of information. And then you should also, in most areas, there are local cancer support and information centres. Sometimes they're called Maggie's centres, sometimes they're Macmillan centres, and everything in between. But there's people there that you can talk to, and there's a whole wealth of information that can be obtained from them. Next slide, please. With 2,000 men on the programme, we do occasionally ask them for feedback. So here are a few quotes we've had from our patients. Oh yeah, I've just been reminded that support groups, they're still out there. Support groups, they are still out there. Some have moved online, some are, there's sort of one person holding the phone or the email rather than getting back face to face yet, but it will be happening. If it's not already, it should start happening, hopefully, once we get this dreadful other C word that's been striking fear into all of our lives sorted. So nervous, but can't imagine going back to straightforward clinic follow-up. Getting on with it, life is good. Taking back control, that's what it's all about. And it's okay if you're not computer literate, although I should imagine if you're watching a webinar you are, but it's okay to have your partner, a child log in for you. That's absolutely fine as long as you've given them your permission. And you can fit things around a calendar. You don't have to think, oh, I'm going to have an outpatient appointment on that date, better not book that concert that just happens to be touring at the same time. So yeah, the feedback from the patients is thoroughly positive, and it's all built around you. I've got another slide with a quote on. So being in the dark, feeling like people aren't talking to you, talking about you, and making decisions without you. So this, I'll let you read that. I don't need to read it out for you. So what we're trying to do is make you the team member, put you in charge again of your own destiny, which you were before cancer entered your lives. So I've got one final slide to summarise. So personalised stratified follow-up or remote follow-up puts you back in the driving seat. Remember to make a note of your own PSA recall level. It may get lost in your GP notes, so it's important that you know what it is. It will be tailored to you, and what your follow-up details are should also be tailored to you. And make sure you know who to contact and what reason to contact them for. This is about supporting you and giving you the tools, but it's also making sure that you don't feel lost. Thank you for listening.
Thank you very much, Debbie, for that. That was really great. It was really interesting to hear. And as promised, now we have some time for questions. So I will also invite Chris back to the screen, and we can tackle some of the questions that have come in. I think probably the first one I'd like to talk about is, so some people have commented that this sounds like there's a lot of sort of money saving going on, and you know what sort of, and that's the priority for the NHS here. Do you think that's fair?
No, and the reality is it isn't about money saving, because the demand for cancer services is going up and up. So we're always spending more money. I think it's about trying to create some capacity within services so that we can meet the demands. As Debbie said, there's so many more patients now that are living well with cancer, that we can't keep asking everybody to come back to hospital for a checkup if they don't need to be there. So there is some drive around trying to create some capacity within clinics so that we can see patients perhaps at the front end. And the other drive is that we know coming back to hospital unnecessarily can cause a lot of anxiety for patients. And people would rather, as Debbie's video was lovely actually, as it showed the patients feeling much happier having that choice and control over their health and well-being in the community. And I think just the other thing to think is when I talked about sort of one size fits all, and I think historically in the NHS, we've identified there's a need for something and then we've created a service. Now, if that service doesn't meet everybody's needs, then actually it's a bit of a waste of money. And people with unmet needs, we know, are going to go to the doctors more, they may end up at A&E more often, and they may have unplanned admissions to hospital. So if we can be flexible in how we deliver that service to people. I mean, a good example is pulmonary rehab services. So traditionally they used to be arranged, there'd perhaps be a church hall and people would be invited to go along and do some exercises. So a lot of money was spent creating these, but then people weren't turning up because actually that wasn't their thing. Whereas having a conversation with that individual about what matters most to them, you may find that doing some gardening or dog walking might meet that person's exercise needs. So I would say it's not, certainly my understanding is the drive isn't about saving money. The drive is about looking at the resources we have and ensuring that we use those most effectively to meet people's needs in a way that matters to them.
Brilliant. Thank you very much. I think this one is probably more directed at Debbie, but do you have a sense of what percentage of trusts now deliver personalised stratified follow-up?
There's certainly more than there were, because during coronavirus, I think it made people sit up and pay attention and look at how they were going to keep patients out of hospital. So in a way, that has forced the hand of people that were perhaps a little bit reluctant to do it previously. And a lot of the reluctance came from clinicians rather than from patients and managers. I can't tell you how many there are, but what I can tell you is that I've been doing quite a lot of webinars with hospitals, Southend, Oxford, somewhere up north, Liverpool way. So I've done quite a few, just sort of sharing the information that we have and helping people to set it up. So if it's not already in your area, it'll be coming there soon.
Fantastic. And how can you be sure that the care that someone receives is really personalised?
Is that for me?
I think, yeah, probably.
So what we tend to do, I know nobody likes to be fitted into little boxes. We're all individuals. And so what we do is we look at what your Gleason score is, what your presenting PSA is, what your T stage is, and what treatment you've had. And what problems and issues you've had. If you've still got ongoing problems, then it may be right that you stay with a urologist who's going to sort out your plumbing that hasn't still recovered, or stay with the care of the nurse specialist who knows your case and can allay your fears. But we want to give you the tools, although there was that screen I shared that went a bit blurry, sorry about that, about what the recall levels are. We do personalise that to each patient. We set each patient up individually And if you've got somebody whose starting PSA was 1800, then we may change things a little bit according to that person, but it is definitely individualised.
Thank you. Thank you for that. Sorry, I realized I muted myself. There was another question that came in asking basically that, well, I'm just finding it. Now it seems to have disappeared. Well, just there we go. One gentleman is registered with the NHS and his GP online, where he communicates with them and can make requests for prescriptions, etc. Will the invitation to personal care be sort of linked to this, or would that be sort of a separate program? You know, do these talk to each other?
I think that one might be for you, Chris. I know that a lot of GP practices do allow patients the option of looking at their own blood results, accessing the blood results as they come into the doctor's surgery. We've got a few that do that, so that's in addition to what we're doing. There's no reason why they can't communicate, but I don't know if it's been set up on the website or the apps yet.
Yeah, I don't know yet. I think person's probably talking about the NHS app, which a lot of us have downloaded since we've had our COVID jabs. And it is quite amazing how much information you can access and what you can do with that app, which is great. I suspect the app will be staying, and in future we'll be doing lots of things through that app. But I suspect at the moment practices probably aren't geared up to enable patients to access that level of information yet, but I'm sure it will come. Technology advancement is moving at a rapid speed, and we're all getting used to using these things. There are patient apps in certain places that link to hospital systems that patients can use. So in some areas there's already that facility using a different app that you can download on your phone. So yeah, not at the moment, I suspect, but probably not far away.
Thank you. And then a question came in about the role of carers. So I think this is sort of directed at you, Chris. There was no mention of the involvement of carers in sort of developing personalised care. Was that purposeful, or was that there? It was sort of wasn't mentioned explicitly.
Yeah, no, I suppose the focus was on about the person as an individual and the importance of what matters to them. If there's a carer in their life, or if indeed they are a carer, then obviously that's going to be very important and matters to them. So we would expect through a person-centered conversation, if somebody wanted their carer involved in that conversation, then absolutely. And it may be that having that meaningful conversation identifies that the carer has needs, and we would expect the healthcare professional to support the carer in having those needs met. But equally, some people may not want the carer involved in a conversation. They may want it to be private. So yeah, no, it wasn't a deliberate omission at all. It was just I was focusing on the individual and what matters to them.
Brilliant. Thank you very much.